Okay. Should I presume that we are all seeing the screen?
Yes.
Is my screen visible? Okay,
it is visible.
Fine. Okay, fine. Thank you. So good afternoon, everyone. Yeah, today we are talking briefly, though, about disorders of immune system. As we are coming towards the end of this module, and hopefully that we have discussed at length about the beauty and the importance of our immune system in this module of immunology. Now we come to talk about a few challenges that may be imposed by this same system to our own bodies. So this afternoon, we are going to talk about hypersensitivity reactions. Then I will only introduce immunodeficiency disorders, and we shall have it as our assignment. Everyone will be obliged to go and read about immunodeficiency disorders, but we shall introduce them nevertheless. So hypersensitivity reactions, commonly termed as allergy. We all know, or we've had, or we've incurred allergic reactions. However much it is not truly correct to correctively term hypersensitivity reactions as allergy, because allergy is only limited to IgE mediated reactions, or what we may call as type 1 immediate hypersensitivity reactions. So that's where we can have the term allergy being appropriately used. So hypersensitivity reactions are basically divided into, hypersensitivity itself, it means that there is an excessive or exaggerated reaction produced by the normal immune system. So in this case, we have an exaggerated, inappropriate reaction produced by the normal immune system, but harmful to the host. So we have 4 types of them. We have type 1, type 2, type 3, and type 4 hypersensitivity reactions. So type 1, type 2, and type 3 are antibody mediated or humoral mediated. Or what mediates these reactions in type 1, type 2, and type 3 are antibodies, as we shall be seeing. Type 4 is cell mediated, so it is mediated by T cell T cells that mediate this reaction. As I've said, that type 1, 2, 3 are antibody mediated reactions or hypersensitivity reactions. Type 1 is mediated by immunoglobulin E. And I presume that we have discussed about antibodies, and is mediated by immunoglobulin E. Then type 2 and type 3, which are antibody mediated, are mediated by IgG and IgM at a lesser extent, but more pronounced IgG. Okay. So this shows the times. So before, type 1 is also known as immediate or anaphylactic. So the occurrence happens in a shorter, brief time. Though we shall see later on, it is also categorized into immediate and late phase anaphylactic reaction. So type 2 is called cytotoxic. We shall see what happens in cytotoxic reactions. Basically, we know what the term cytotoxic means. There is an attack on a cell. So basically in type 2, what happens in type 2 is that we have some cells that normally contain antigens on the surface of those cells, call them antigens on the membrane, of the cell membrane. For instance, red blood cells. So red blood cells have antigens. Those antigens that determine the blood type, as you will appreciate later on when you talk about transfusional medicine or hematology. I think it will be later in third year. So what we've heard about, what we know as blood group A, blood group B, blood group O, those actually refer to antigens.
Sensitivity, excessive desirable.
I pray that we can pay some attention. So in cytotoxic, for instance, if we have an A antigen on the surface of the red blood cell, so antibodies against those cell surface antigens lead to cytotoxic reactions as a result of MAC, what we've seen as an end product of complement system that results into formation of membrane attack complex that distracts or lyses cells. So in immune complex, basically it's antibody antigen complexes. They may be deposited. I think last semester, in our first semester, we remember we talked about immunological reactions of streptococcal infections. If we can recall the glomerulonephritis and rheumatoid arthritis. So those are the classical examples of type 3 immune complex hypersensitivity reactions. Then, as I've said, then type 4 is cell mediated. So type 1 or anaphylactic or immediate, time before clinical signs and symptoms, within less than 30 minutes, the reaction has already taken place. So basically, the IgE binds the mast cells or basophils because causes degranulation of mast cells or basophils and release the pharmacologically active mediators, an example being histamine, but we shall see several examples of mediators that are released in this case. So in type 1, what we've seen classically is that we have IgE that mediates these reactions. If we can recall previously what you discussed in complement, IgE does not activate complement cascade. It's only IgM and IgG that ably activate complement. So meaning that in type 1, anaphylactic or immediate hypersensitivity, we do not have complement cascade being activated. But why do we have IgE instead of other? So we shall look when we go in front, we shall see at in example atopy, the genetic tendency of a person being allergic. So in atopy, there is an increased production of IgE. And what brings that? When there is an interaction between, when there is an exposure, when your body gets exposed to an antigen, instead of forming IgG, which is immediately formed after class switching from IgM, Why do we form IgE? So there are reasons as to why in those atopic individuals, those people with tendencies of having allergic, which is also familial, there is that increase in IgE production. So in type 2 cytotoxic, basically 5 to 12 hours before presentation of symptoms. Antigen causes formation of IgM and IgG antibodies that bind to target cells. When combined with action of complement, destroys target cell by the action of MAC. And I think you remember that MAC. Type 3, 3 to 8 hours. So I've already talked about the immune complex. Antibodies and antigens form complexes that cause damage by inflammation. We shall see the process as well, where we have other cytokines that bring about or chemoattractants or chemokines that lead to immigration of neutrophils, which later produce enzymes that lead to damage or tissue damage. Type 4 antigens cause formation of cytotoxic T cells that kill target cells, and it is called also known as delayed type of hypersensitivity at least 24 hours and above. So these are immunological aspects of hypersensitivity reactions. So in type 1, the allergen induces antigen or an allergen. It induces IgE antibody production, which binds to mast cells and basophils. Then when that is in primary exposure, then when exposed again to the same allergen or antigen, the allergen cross-links the bound IgE on those mast cells or basophils, leading to degranulation and release of mediators. Cytotoxic antigens on the surface, on the cell surface, combined with IgG antibody, leads to activation of complement and thus formation of membrane attack complex that lyses the cells which harbors the antigen. For example, red blood cells, where we shall see hemolytic anemias, and rhesus, also the rhesus-associated lysis of cells, like in hemolytic disease of the newborn. Type 3, antigen antibody immune complexes are deposited in tissues or even in the inner lining of the blood vessels, leading to activation of complement and poromethynuclear cells attracted to that site, release of lysosomal enzymes causing tissue damage. Then 4, delayed hypersensitivity. T cell lymphocytes activated or sensitized by the antigen release, lymphokines upon second contact with the same antigen. The lymphokines induce inflammation and activate macrophages. So in type 4, basically, we have two types of cells, two kinds of cells that play a role, and that is T lymphocytes and macrophages combinedly play a role or mediate this kind of hypersensitivity reaction. So now type 1, or immediate hypersensitivity reaction, occur within minutes of exposure to antigen. The antigen is combined with the IgE antibodies. The IgE bind binds to mast cells and basophils, causing them to undergo deep granulation and release of several mediators. So we have a number of mediators that can be released. So by mast cells or basophils, histamine being the leading mediator that plays a role in anaphylactic or immediate hypersensitivity reactions. Then we have prostaglandins, we have leukotrienes. Some act immediately, others act in a late phase or later on, because we shall see that we have the late phase of the immediate hypersensitivity reaction. So the very challenging clinical occurrence is an anaphylactic shock, massive drop in blood pressure, and it can be fatal in minutes. So the sequence of events in IgE-mediated hypersensitivity. So as we've already said, what happens is the exposure of the body to an allergen or an antigen. So in the primary exposure or your first time exposure, what happens is that antigen induces the formation of IgE from B cells, from plasma cells, or which are also come from B cells. So there is that predisposition of that is basically in atopic individuals. But normally, when a person gets exposed to an antigen, an immunoglobulin that is supposed to be produced first is IgG, not IgE. But in those atopic individuals, there is a predisposition because of some factors that we shall, but basically what happens, there is accumulation of Th2. I think we've covered those classes, subclasses of T lymphocytes. We have T helper T cell, subclass Th1, subclass Th2. So in atopic individuals, in their tissues, they have accumulation of Th2, and Th2 cells produce or release cytokine interleukin 4. Interleukin 4 is associated with the class switch, changing the class or switching the class from IgG that is essentially supposed to be produced in the first interact with an antigen. Now it switches class to IgE. So that's what happens in allergic or atopic individuals. Basically, there is a genetic predisposition. You are genetically inclined to have that reaction. So in the first exposure, IgE antibody produced in response to allergen. Then in subsequent exposure to that antigen, now we have the antigen again binding to already preformed IgE, which is bound on the surfaces of mast cells and on mast cells and basophils. Something to note that I did not include in my notice is that these mast cells and basophils do not have receptors to IgG. So we cannot have mast cells release pharmacologically active mediators as a result of attachment of IgG to the surface of mast cells. We do not have receptors. So we have high affinity of IgE on the cell surface of mast cells and basophils. So the second exposure leads to cross-linking of IgE antibodies on the surfaces of mast cells, and the cross-linking leads to degranulation of these cells to release these mediators, an example being histamine. So we have phases of anaphylactic shock, hypersensitivity. So we have sensitization phase where IgE produced in response to the antigen, what we've just discussed. So IgE binds to the FC receptor on the mast cells or basophils. So mast cells get sensitized. So we have activation phase. On the second visit of the same antigen specific, remember here we are dealing with the specificity. So activation phase, on the next encounter with the antigen cross-links IgE receptors on the mast cells using the Fab receptors, leading to immediate granulation. Mast cells granulation can also occur with IgE antibodies, some chemicals, or complement anaphylactoxins. Then we have the effector, where now these. Yes, please.
We have some people who have not muted their mics, and we are finding it a challenge to follow. Some echoes keep coming. Yeah?
Yeah, I thought we are a class. I did not have a code to claim host being a host.
I'm seeing Edith's mic is on.
Yeah, let the concerned individuals be a little. Let's be civil and get done with this. Hello, can someone hear me?
Yes, doctor. Yes, doctor.
Yeah, my network has issues. Okay. So we have effector phase, where tissue reaction to degranulation, vesicular permeability, mucus secretion, So we have the clinical presentation or clinical effects as a result of these mediators. And some of them are those vesicular permeability, smooth muscle contractions. We have mucus secretions, bronchoconstrictions, what we shall see in asthmatic patients. So this is a diagrammatic presentation in immediate or anaphylactic hypersensitivity. So what happens basically, this is a mast cell contained with granules. These granules are filled with histamine or mediators. Then I've said the mast cells have high affinity for IgE using the FC portion. So mast cell with IgE bound to surface, mediators contained within granules in the cytoplasm. So that is after sensitization, basically. So after the second encounter with an antigen, the antigen cross-links the bound IgE on the surface of the mast cell, and this activates the mast cell to degranulate and release these granules containing mediators, for instance, histamine. So mediators, e.g. histamine, released from mast cells. So basically, this is the sequence of occurrences that happen in immediate phase or immediate or anaphylactic hypersensitivity reaction. I think everyone is now off, has muted. Let's be civil. Okay, so clinical effects. So now we have mucocutaneous, we have pruritus, flushing, erythema, urticaria, as we shall be seeing the hives, angioedema. In respiratory, which is most common and very actually life-threatening, where now the asthmatic occurrences happen. We have upper airway angioedema, or that is mucus secretion. Then we have a bronchoconstriction, which is more profound in asthmatic patients. Pulmonary hyperinflation with or without pulmonary edema. In vesicular, we have vasodilation and vesicular permeability, which is so common that now leads to migration of those cells, like poromorphonuclear cells, to the site if it is local, because we have local and systemic. And in systemic, that's where we have anaphylactic shock. In local, that's where we have these urticaria, the erythema, and eschisma, and so forth. So in those, we have the migration of neutrophils from blood circulation to the affected site if it is local. So now that happens only as a result of vesicular permeability to allow those cells to escape from the blood circulation, circulatory system to the affected tissues. GIT, cramping, vomiting, and diarrhea. Then we have now mediators. So mediators, we have primary mediators and we have secondary mediators, basically those that act in late phase of anaphylactic hypersensitivity. So primary mediators, we have histamine, we have serotonin, we have heparin, which is an anticoagulant, and then we have chemotactic factors. For example, eosinophil chemotactic factor, which leads to recruitment of eosinophil or neutrophils to the site of the reaction. So basically, histamine occurs in granules of tissue mast cells and basophils in a preformed state. What does that one imply? It implies that it is ready to act. Its actions are immediate because it is already in preformed state in those mast cells and basophils. Okay, so it really causes vasodilation, causes increased capillary permeability, and also smooth muscle contractions, as we see what happens in bronchoconstrictions in asthmatic patients. So clinically, disorders such as allergic rhinitis, or what we know as hay fever, urticaria, and angioedema occur as a result of the effects of histamine. Okay, so then we have the eosinophil chemotactic factor of anaphylaxis, which basically recruits the eosinophils, neutrophils at the site. The role of eosinophil, though, is not certain, but in sometimes it is associated with the release of histaminase enzyme. So histaminase enzyme basically breaks down histamine, and that it is associated with a relief effect of allergy. Serotonin is also found in a preformed state in mast cells and blood platelets. when released during anaphylaxis, it causes capillary dilation, increased vesicular permeability, and smooth muscle contraction, but on a minor importance compared to above histamine. Prostaglandins, so basically the secondary mediators, prostaglandins and leukotrienes, come as a result of arachidonic acid metabolism. Arachidonic acid metabolism in one pathway forms leukotrienes, collectively known as slow reacting substance of anaphylaxis, or SRSA. And then in another pathway, it forms prostaglandins. Okay, so prostaglandins are related to leukotrienes, basically because they both come from arachidonic acid metabolism. They cause dilation and increased permeability of capillaries and bronchoconstriction. So we have also the platelet activating factor. So platelet activating factor, it may lead to thrombocytopenia, and low levels of thrombocytopenia result into continuous or uncontrolled bleeding or bleeding tendencies. Hello? Can someone hear me?
Yes,
Yes.
Okay, so
Yes.
cytokines contribute to hypersensitivity type 1 response. I briefly told you how some come about. Interleukin 4-5 are secreted by Th2 subtype cells. Interleukin 6 and tissue necrosis factor are secreted by macrophages. So interleukin 4 helps to activate B cell, which in turn increases IgE production. So that's now the link. Why some individuals are atopic and others are not atopic. Or some are allergic, or why some families are allergic or have allergy tendencies and other families are not. So basically the difference lies here. In those that are allergic or have allergic tendencies or atopic tendencies, they have high levels of interleukin 4 produced by Th2 cells or helper T cell subclass 2. So these individuals with high levels of interleukin 4, which helps to activate B cells. And this activation actually communicates that this B cell or activated plasma cell only produces IgE instead of other immunoglobulin. So this communication dictates the class switching from IgM, that is essentially supposed to be produced, IgG, not IgM, because the first immunoglobulin produced in case of an interaction with an antigen is IgM, I mean IgG, because IgM already exists on B cell. I hope you understand that. We have IgM already present on B cells. So what happens when there is an exposure to an antigen, IgM class switches to form IgG. But in atopic, in allergic patients, instead of forming IgG, the body is guided to produce IgE. Interleukin 5, also produced by Th2 cells, recruits eosinophils. Interleukin 6 as a result of macrophages contribute to inflammation and fever. Eosinophils increased in atopic individuals have low affinity receptor for IgE. Degranulation as a result of a platelet activating factor, prostaglandins, and leukotrienes, important in late phase asthma. So there is a tendency of developed countries or hygienic environments being predisposed to allergies. Statistics mention that in America, almost 40% of the American population have hypersensitivity reactions, especially type 1. So there is a hypothesis known as hygiene hypothesis. In this hypothesis, basically, IgE in normal situation is supposed to counteract or fight against parasites. So in a parasitic infection, the first immunoglobulin supposed to be produced is IgE, not IgG. So now in developed countries, because we already have IgE in circulation, which is supposed to play a role in parasitic infections, it ends up playing a role in mediating type 1 immediate or anaphylactic hypersensitivity reactions. Contrary to undeveloped countries, because the high produced levels of IgE, if you are infected with endoparasites or ectopic parasites, whichever, now the IgE will have a role, will be preoccupied in fighting against parasitic infections, and thus someone will not be predisposed to developing allergic reactions. Am I making myself clear on that point?
Pardon, sir.
Yes,
You're clear.
You are clear.
I beg your pardon, sir.
Pardon.
Okay. There is.
I just got confused.
Sorry?
Doctor, I beg your pardon.
Okay. So there is a hypothesis known as hygiene hypothesis, especially in anaphylactic hypersensitivity. So what I'm saying is that we've seen that in type 1 hypersensitivity, IgE is the immunoglobulin that mediates these reactions. So in hygienic world or environments, the IgE, before we get there, basically immunoglobulin E, before even we talk about immunology or allergy or hypersensitivity, immunoglobulin E is supposed to play a role in parasitic infections normally, without allergies, without hypersensitivity. IgG and IgM are for bacterial infections. And we shall see T cells are for cancer cells. But IgE is for parasitic. So in parasitic infected individuals, we have high levels of IgE, high levels of eosinophils. So the classical importance or role of IgE is to fight against or protect our bodies against parasitic infections. That is now the standard. Now, from that standard, why developed countries, why there is a statistical claim that 40% of an American population is at least predisposed or have encountered type 1 hypersensitivity reactions, is basically the reason is the IgE that is essentially supposed to fight against parasitic infections, in these developed countries, we no longer encounter parasitic infections. So the IgE that is supposed to do that role is actually now it is resulted into mediating anaphylactic hypersensitivity reactions. Contrary to undeveloped countries, which are infested with parasitic infections, including our setting here. So in our setting, high levels of IgE circulating in our bodies and in our tissues, they are preoccupied with their primary fundamental role of protecting or fighting against the infested parasitic infections. I hope we are on the same page via that.
Yes, sir.
Okay, let's proceed. So these are biological effects of mast cell mediators. So we have different systems. So we have histamine, we have PAF or platelet activating factor, prostaglandins, and leukotrienes. So histamine acts on the blood vessels, resulting into vesicular permeability and escape of some cells to the affected sites or to where they are needed. Also leads to bronchoconstriction or smooth muscle constrictions. What we see in asthma, we can see here the bronchi. So bronchoconstriction leading to these muscles to constrict and leading to breathlessness. Then also GIT, we have seen what happens in GIT. Then we have tissue necrosis factor and also these secondary mediators leading to inflammation, enzymes, tissue remodeling. So we have in hypersensitivity type 1, we have both localized and systemic. Localized, also known as atopy, the genetical tendency of someone to have inflammation as a result of immediate or anaphylactic hypersensitivity. Cutaneous anaphylaxis, where we have erythema, where we have wheal and flare. So basically, wheals are like swellings, then flare are reddening of. So we have, when we see in this photo, this is the wheal we are talking about. Then this entire reddening is the one known as flare. We have urticaria, what are known as hives as well. Allergic rhinitis and conjunctivitis, also known as hay fever, where we have runny nose, we have itchy eyes, and at times even teary is very common. That's what we call as hay fever, and as a result of immediate anaphylactic hypersensitivity reaction. So basically, it's as a result of so many allergens. We have food allergies, where like someone is allergic to shellfish, the peanuts. Atopic dermatitis, we have seen this nickel coin. Someone was allergic to this nickel coin and leads to atopic dermatitis. Then we also have asthma or lower respiratory tract constriction. Then in systemic anaphylaxis, which is the worst occurrence of type 1, we have anaphylactic shock as the pronounced feature. Mast cells degranulation all over, or there is systemic degranulation of mast cells, 3 potentially fatal reactions, laryngeal edema or fluid leaking out leading to swelling, bronchial constriction leading to suffocation, peripheral edema, which results into shock from fluid loss, because there is increased vesicular permeability leading to escape of intravesicular fluid, and thus resulting into shock. Secondary mediators cause prolonged effects later or later phase reaction. So basically, in a late phase reaction of IgE mediated inflammation, it occurs approximately 6 hours after exposure to the antigen. And it is due to mediators of the late phase, for example, the leukotrienes. So these mediators cause an influx of inflammatory cells such as neutrophils and eosinophils, and symptoms such as erythema, induration occur. And I've talked of, so I think I've told you that we do not have complement taking place in type 1 hypersensitivity. Reason, IgE, which mediates these reactions, does not activate complement. Treatment, avoiding allergens. We have fomites, we have pollen, we have farm substances, we have drugs. So all those actually elicit type 1 hypersensitivity reactions. So prevention is very key. Drugs, antihistamines compete with histamine for receptors and counteract the activities or effects of histamine. Epinephrine is the drug of choice, best immediate treatment for anaphylactic shock. It reverses the effects of granules and thus the mediators, and it is quick acting, but the problem, it is short-lived, it has a short duration. Then the steroids, which block histamine synthesis, e.g. PRED, stabilizers of cells. We see now that's where we have our inhalers, stabilizers. Then we have inhaled beta adrenergic bronchodilators, an example being salbutamol. So salbutamol is usually used in our handheld inhalers to counteract the effects of asthma. That's it for type 1, unless we have a question before we proceed to type 2. Any question? Hello? Are we still there?
Yes, you are here, doctor.
Okay,
Let's proceed.
You can
okay,
proceed.
let's proceed.
Excuse me.
There is
Hello?
someone. Okay, yes.
Can type 1 hypersensitivity localized lead to systemic in type 1 hypersensitivity?
No, it's from the onset of the reaction. The onset either starts as a localized reaction or as a systemic reaction. And what predetermines that? 1, the nature of the allergen. 2, the distribution of the IgE specific to that allergen or antigen. If the distribution is systemic all over the body, then you expect a systemic reaction. If the distribution is localized, say in the skin, then we shall have a localized hypersensitivity of the skin, where we shall see erythema and the Archaea hives and so forth. I think we can proceed now. Type 2.
Excuse me, sir.
Yes, someone has a question.
Yeah, mine is about the atopy thing. Like I wanted to ask like what's the relationship between someone who gets a skin atopy with getting an infection of eczema herpeticulum?
Sorry, I beg your pardon.
Like
Hello?
usually, okay, they say that someone who gets like, hello?
Hello, yes, we can hear you.
Yeah, they say that someone who gets eczema herpeticulum, like the risk factor is usually associated with having atopy, like localized anaphylactic reactions. So like what could be like the etiology behind that?
So I think, did we understand what atopy is? So atopy basically is a genetic tendency to develop allergic reactions where eczema is part of the allergic reactions. So indeed, someone who gets all those reactions, including eczema, are atopic. They have allergic tendencies, or they are atopic individuals. Am I making myself clear to someone who has asked?
Yes,
The
sir.
explanation is in atopy, an individual is predisposed to developing hypersensitivity type 1 reactions. Among the reactions, it's where we are seeing the eczema, among others, depending on one, the antigen, two, the site of the mast cells, which already are bound to IgE. So that's what explains the fateful effects of eczema. Okay, type 2.
Excuse me.
Yes,
Excuse me.
yes. Yeah.
About the theory you told us.
Sorry?
About the theory you told us.
Yeah.
For me, I thought all the IGs are supposed to be specific, maybe to a certain antigen. Again,
Sorry?
I thought the IGs
Yes.
Are specific to a certain antigen.
Absolutely true.
Why should we have transfer of maybe their activity against a parasite that's supposed to attack? Then we attribute them towards the hypersensitivity reactions.
Here, what we are talking about IgEs before they get specific to a certain element. Okay, now remember how borrow the knowledge of sensitization and how these antibodies are produced. There is sensitization. The sensitization, the primary first occurrence of the antigen. Let it be the parasite, let it be the bacteria, let it be what? But as I've said, in the production of antibodies, the so-called specific antibodies, they are predetermined by which type of the antigen it is. If it is a bacterium, then there is a preference, there is preferential production of IgG. Now, what will be produced thereafter will be specific to that antigen that has produced it. But in a parasitic infection, you will not expect to produce an IgG specific to those parasitic antigens. No. You expect to have specific IgE specific to the antigens of the parasite. Now, in instances where we have low levels of parasitic infections, the class IgE still in its B cell before it is differentiated into a specific antibody, then it can be used, there can be class switching to form as a result of those indicators or determinants. The determinants I've told you, interleukin or cytokine interleukin 4, which triggers B cell to only produce IgE. That is in atopic individuals. Instead of say producing IgG, there is a command that B cell please produce IgE against that allergen. The mother of the babies can give us a favor and mute. So basically, we shall have more insights upon reading. That's why I encourage each and every one, and it should be, I re-echo it once again. Do not depend on our PowerPoints. They are very, very much summarized and they lack information. We cannot squeeze each and everything. Our PowerPoints cannot lead to thorough understanding of a topic. Okay, cytotoxic hypersensitivity or type 1. It involves IgG and IgM as mediators. So as I've said earlier on, Madame Goretti, kindly excuse us and mute your microphone. Mudora Goretti. Okay, let's proceed. So I hope I can be heard.
Yes, doctor.
Okay. So cytotoxic hypersensitivity or type 1 involves antibodies IgG and IgM, but more importantly, IgG is more pronounced compared to IgM. And as we've said earlier on, these antibodies, IgG and IgM, have the ability to activate complement. So complement plays a big role in cytotoxicity, hypersensitivity type 2 reactions. So antigenic cell is lysed. Antigenic cell, meaning a cell which contains or bears an antigen on its membrane or cell surface. Classically, we have transfusion reactions. ABO, blood group system. Incompatible donor cells are lysed as a result of the activation of complement. So we shall see how it happens. We also have the rhesus. Even though we have you've not studied ABO blood grouping in hematology, at least we all know our blood groups. And there is this saying of, say, I am blood group A plus. So the plus means the rhesus factor. The means it is you're positive. You have the antigen, rhesus B antigen. In addition to A antigen, B antigen, or AB antigen, you also have, okay, we shall appreciate what happens in front. So rhesus blood group system, 80% of the population being rhesus positive, and those who are rhesus negative can be sensitized to destroy rhesus positive blood cells, as we shall see in hemolytic disease of the newborn. antibody-mediated cytotoxicity, antibodies versus cell surface antigens result into cell lysis, or antibody-dependent cellular cytotoxicity. You need to write that down such that you don't forget about it. So most common hypersensitivity type 2 reactions involve red blood cells. And we've seen what happens with the red blood cells, transfusion reactions, hemolytic disease of the newborn, autoimmune hemolytic anemias. So this is the human ABO blood typing. In the first column, we have the genotype. In the second column, we have the phenotype of now what we know. Hello?
Yes,
Yes.
doctor.
Man,
Yes.
I'm back. I'm not the one who brought technology and Ebola and Corona. Okay. So I hope everyone understands what we are talking about here. So in genotype, let's consider column 2, red blood cell phenotype, or literally our blood group. So when someone is blood group A, that blood cell group A. Hello? Hello?
Yes.
So we can hear you.
Okay.
But your network is breaking.
My network has issues. Okay, let's continue, we shall see. So basically, the antigens on blood group A, we have antigen A and antigen H on the surface of red blood cells of an individual with blood group A. So this individual, his or her body produces antibodies against at birth, slightly after birth. The individual produces antibodies against the antigens that he or she does not bear on the red blood cells. So in the case of blood group A, an individual produces anti-B antibodies. Is that one clear? Hello?
Yes, doctor, it is clear.
Yeah. Okay. So the same applies to blood group B. Someone has antigen B and H and produces in the serum, you find antibodies against antigen A because that person does not bear antigen A on the surface of red blood cells. So someone with AB blood group means that person has antigens A, antigen B, antigen H. And in so doing, because he has all the antigens, his or her body does not produce any antibodies against these because intrinsically the body is sensitized that these are own antigens. So please do not produce antibodies against these antigens. In O, most of you actually, the prevalence in Africa, most of you are blood group O. So in blood group O, the genotype is OOH. So means that the only antigen, so H is a constant. And in most cases, it is usually omitted. So in blood group O, person only has one antigen, which is H. And thus, you'll find that in the serum or in the body of that individual with blood group O produces anti-A and anti-B antibodies against antigens A and antigen B because they are deficit or they do not appear on the surface of red blood cell. So this is ABO blood typing. Then we also have rhesus blood
Excuse me,
typing.
doctor. Excuse me, doctor.
Sir. Yes, please.
In my knowledge, for me, I thought the antibodies are always produced in response to an antigen. So in this case, where you're saying we have antibodies be produced in blood group A, which kind of stimulus is there to stimulate the production of antibodies?
It might. This is an entire lecture that you guys will enjoy when you reach in hematology. But I've told you that at birth, slightly after birth, when, and even in embryogenesis, when your body has started to form blood and depending on your parents, of course, that the blood type, if your blood type is, say, blood type A, naturally there is a communication to the environment because these A antigens on the surface of red blood cell, they are taken as own. Now, the body in a process that I may not recall, it's over 10 years that I studied hematology, the body is directed in a process to form or to produce antibodies against the missing antigens on your red blood cells. So this is what happens actually in allografts rejection and transfusion disorders. So when someone already has that, that's why you, an individual who is A, blood group A, cannot receive blood group B because you already have circulating antibodies against blood group B. That's what leads to transfusion reaction or transfusion disorders. The precise mechanism, wait for hematology or transfusion medicine. Hemolytic transfusion reactions. So ABO incompatible transfusion can lead to immediate disaster. IgM binds to red blood cells, activate complement. This leads to intravascular lysis by MAC, renal failure, and death. Clinical symptoms, we have hemolysis. Treatment, stopping transfusion, then also infusion with diuretics. Prevent by cross-match. So this is how we prevent occurrence of such hemolytic transfusions during a cross-match. So basically in a cross-match, a patient who is supposed to be a recipient, a blood recipient, we get the serum of that patient. The serum essentially has the antibodies, saturating antibodies. We mix it with the donor red blood cells, which contain antigens on the surface of red blood cell. Then you mix, and then when there is agglutination, then you know that there is a reaction which has taken place, and thus there is an incompatible, or this donor is an incompatible donor. When there is no agglutination, then there is matching, and you can go ahead and transfuse blood to the recipient. So what happens is this. On a red blood cell, normally, it contains antigens. Either antigen A, if your blood group A, or antigen RHD or rhesus D, if your blood group A positive or A rhesus D positive. So during type 2 hypersensitivity, what happens, there is the IgG binds to the antigen on the membrane, either during the poor cross-matching, transfusion of the wrong blood, or during hemolytic disease of the newborn, as I will explain ahead. So what happens, the antibodies against that blood group antigen, there is attachment. So this attachment now brings about activation of complement. Activation of complement leads to formation of MAC, which destroys the integrity of this red blood cell, leading to lysis or hemolysis. Involves, so now we are talking about the hemolytic disease of the newborn. Hello, am I still audible?
Audio.
Yes.
Yes, sir.
Okay. So basically, in hemolytic disease of the newborn, it literally means that we have a mother who is blood group A, blood group O, rhesus negative. Is that clear? We have a mother who is blood group O negative or rhesus negative, implying that that person bears no antigen apart from antigen H, bears no antigen on the surface of red blood cells. So during the first pregnancy, when the fetus is rhesus positive, because probably the fetus has inherited it from the father, there is sensitization. During childbirth, at that point of birth, that the fetuses or newborn's blood mixes with the mother's blood. Remember, the mother's blood does not contain any antigen, Now the blood gets sensitized or exposed to the antigens of the blood of the fetus, of the newborn. Now the body of the mother gets sensitized and forms antibodies against rhesus factor or rhesus D. Are we clear?
We are there, doctor.
So we have now the mother has a saturating antibodies in the blood against rhesus factor D. In any case, if that mother is not immunized, is not prevented, the subsequent pregnancy, when the mother conceives again, of course, the first pregnancy, the child is okay, is not affected. But what happens, the mother is sensitized and has now circulating antibodies against rhesus factor. So in subsequent pregnancy, what happens, the antibodies cross through the placenta from the mother to the fetus and hemorrhage antigens on the surface of the red blood cells of that fetus, second pregnancy. So that's what is termed as erythroblastosis fetalis. There is hemolysis as a result of antibodies from the mother against antigens on the blood cells of the fetus. But this can be prevented, and thanks to those that invented this, and now we can save lives of babies from blood or negative mothers. So we have ROGAM. It is an anti-rhesus immunoglobulin. So this one is injected immediately after birth, and it counteracts the antibodies which are formed by the mother's body. So now, even in the during the second pregnancy, the baby is safe, is protected against the antibodies from the mother as a result of that immunoglobulin ROGAM. So this is the diagrammatic explanation of what happens in this side. The left side is basically when there is no ROGAM injected in O negative mother. Then this is what happens when there is treatment with ROGAM. So basically, this is a baby who has antigen. The red blood cells of the baby has rhesus factor antigen on the surface of red blood cell. So this is the maternal. So during childbirth, during delivery, there is mixing of blood of the fetus and the blood of the mother. So the mother gets sensitized. So basically gets the antigens get introduced in her body. So the antigen induced formation of antibodies. So now we have antibodies here and rhesus factor, IgM and memory cell. So during the second pregnancy here, now we have a mother who is sensitized. That is if there is no injection with ROGAM. The mother who is already sensitized has circulating antibodies against the rhesus factor and also has memory cells of anti-rhesus factor. So what happens is that get re-exposed or second time exposure, and the antibodies, these are antibodies, IgG now, against the rhesus factor. They cross through the placenta from mother's body, cross through the placenta to the fetus, and now we have antibody antigen, the antigen on the surface of red blood, the rhesus factor antigen. on the surface of red blood cell. So we have the antigen antibody reaction, which activates complement. Complement forms MAC, and MAC will lyse this red blood cell, leading to the condition that we term as hemolytic disease of the fetus and the newborn, commonly known as hemolytic disease of the newborn. Is that clear?
Excuse me, sir.
Yes, the two of you. The lady first.
Doctor, I was inquiring.
Yes,
Are we
ma'am.
supposed to give the ROGAM like after even the second birth?
Yes, they usually take the ROGAM every birth.
Okay, thank you, sir.
Yes,
Doctor,
gentlemen.
I have two questions.
Yes, sir.
One is you said that actually is an example of a mother who is O rhesus factor D negative.
Yes.
Does it mean that even it cannot apply to those with blood group A or blood group B?
No,
Still
this
with a
one is
negative.
no. This happens when there is entirely no antigen on the surfaces of the red blood cell. So it does not happen with blood group A, blood group B rhesus negative. No, it doesn't happen. It only happens during in mothers who are blood group O rhesus negative. So there is entirety absence of antigens on the surfaces of red blood cells.
Then the second question, when we are looking at ABO system,
Yes, sir.
we looked at H antigen.
Sorry?
What is H? We looked at H antigen. Eh?
Yes, I told you that it is usually omitted and it has no effect in typing of blood cells and even cross reactions.
Okay, doctor.
So it is a docile or dormant antigen. Okay.
Okay, doctor.
Excuse me, doctor.
And
Hello?
the last one, yes?
Yes, assuming the mother has already lost the fetus due to HD, can she still be pregnancy survives? Oh, it is already late.
No, when you've lost, you've lost. It leads to death because what happens actually, there is hemolysis of red blood cells, which leads to issues with the brain and results into death. Because remember the importance of oxygen, of red blood cells, transportation of oxygen to tissues. So in most cases, it is associated with even premature stillbirth.
Excuse me, doctor.
My question was about like after the fetus is already been, now they remove that one. Now what about the subsequent pregnancies? Yes. Can the baby survive even when she has been given ROGAM?
Yes, when found that the mother has lost the pregnancy as a result of hemolytic disease of the newborn, the mother can receive ROGAM, and then subsequent pregnancies are okay.
Excuse me, sir.
One last one. We need to proceed. Yes.
I actually think that now they do a lot of screening during antenatal for these particular irregularities.
Very much true. But
that is one of the ways in which isoimmunization has greatly been reduced. So as part of the antenatal care services that are rendered, like in most of the places I see, this type of investigation is done, and the critical attention is paid to the mother.
Yes.
To ensure that the outcome is a good one.
Yes, that is only true and only happens to be true when a mother gets an antenatal care. And not be deceived that 100% of the mother population in Uganda And even, yes, in Africa, they go and receive antenatal. Yes, true, most of them do, but we still have a population which does not go for antenatals, and we still have cases of hemolytic disease of the newborn. So in normal antenatal care, what they do, it is a must to determine the blood group of a mother. The essence of determining the blood group is not that they want to prepare for a transfusion, it's because they want to know the fate of the subsequent, that is for a first timer, the fate of the subsequent pregnancies. So if the person is found to be negative, then at birth, you are given ROGAM. Yes, there is a question.
Doctor, is it the same case when the mother is O rhesus factor D positive and the fetus is negative?
No, that one is okay. It only happens in only one category. I have told you that this issue happens in entirety deficit of antigens. Now we have a mother who is rhesus positive. In this case, we cannot incur hemolytic disease of the newborn. Let's continue, brothers and sisters.
Doctor.
Drugs like penicillin can attach to surfaces of proteins on red blood cells, leading to antibody formation. So some drugs are found to also elicit antibodies against. So when a drug, or what we can call a hapten in this case, can someone tell me what a hapten is? Only one person. Anyway, let's continue. So drugs,
excuse me,
yes?
A hapten is a chemical substance which has a low molecular weight and it cannot elicit an immunological response. But once bound to a protein, it can elicit an immunological response.
Thank you. So that's all. So what happens in this case, when someone has allergies of, say, drug like penicillin, in most cases, actually it happens, and that's why most of them are being phased out slowly. They are broken down into smaller, lower molecular weight molecules known as haptens. But once they attach to proteins on the surface of red blood cells, that combination leads to formation. It has the ability to elicit immunological response, leading to formation of antibodies. So those antibodies now they are specific and they can attach to those proteins on the surface of red blood cells, leading to activation of complement and inflammation, and complement and lysis of the same cell. So the same happens in autoimmune antibodies interact with the red blood cell surface, leading to hemolysis. Quinine can attach to platelets and induce autoantibodies that lyse the platelets, leading thrombocytopenia and thus leading breeding tendencies. In rheumatic fever, antibodies versus group A streptococci cross-react with cardiac tissue, leading to rheumatic fever. In good pasture syndrome, antibody to basement membrane of the kidney and lungs bind to the same membranes and activate complement, which result into tissue damage. So that's all about type 2. Now type 3. Why didn't you tell me that I activated my... Stop misbehaving. Okay, what if the lecture was given in a bedroom? Type 3, which is now immunocomplex, and we talked about them, antibody-antigen complexes being deposited in tissues, resulting into inflammation and complement, destructing or destroying or damaging the tissues in common. So it involves reactions against soluble antigens circulating in serum. Antigen-antibody immune complexes are deposited in organs, activate complement, and cause inflammatory damage. If we remember, glomerulonephritis, inflammation of kidney damage, inflammatory kidney damage occurs when slightly high antigen-antibody ratio is present. Also known as immune complex hypersensitivity, may be general, like in serum sickness, as we shall see what happens, or it may be localized, like in Athers reaction. So in localized, like in skin, we have systemic lupus erythematosus-like reactions or Athers reaction. Kidneys, lupus nephritis, lungs, aspergillosis. Have we covered mycology? Yes. Have you guys covered mycology?
Dr.
Yes,
Alassane.
sir.
Yes.
Okay, yes. So we know aspergillosis and aspergillus borer.
Yes, doctor.
Ever heard of aspergillus borer and what makes it to happen? So basically, that's immunology. The aspergillus borer is not as a result of the fungus, but it's as a result of immunological response because of the infection. So that is type 3 hypersensitivity. Antibodies against the aspergillus antigens and antibodies and against antigens. They form immunocomplexes which are deposited in the alveoli of the lungs, forming what we call as aspergillus borer. Go and refer to your previous notes or you graduated. Blood vessels, polyarthritis, that is inflammation of arteries of small and medium size, joints, rheumatoid arthritis, and others. This reaction may be due to pathogenic mechanism of disease caused by many microorganisms. So IgG or IgM activate complement, then characterized by formation of complexes leading to tissue damage. Examples, we have serum sickness. In this, disease caused by antibody produced to horse or bovine serum. So basically in serum sickness, as we've said, it is a systemic reaction contrary to Athers. So in Athers, we have a localized, but in systemic serum sickness, inflammatory response to the presence of immune complexes deposited in many areas of the body. So many areas of the body are involved. After injection of the foreign serum, the antigen is excreted slowly. The antibody production now starts. So that's what happens in serum sickness. Athers reaction, dermatome inflammatory response caused by reaction of antibody antigen in the skin. So basically, the name is given to inflammation caused by deposition of immune complexes at a localized site. So after the antigen antibody and complement are deposited in vessels, on vessel walls, promenuclear cell infiltration and intravascular clamping of platelets can occur. Those reactions lead to vesicular occlusion, which at times may lead to necrosis. So this is a diagrammatic representation. So we have the antibody antigen complexes circulating. So we may have some at the basement of the vessel, of the blood vessel here. So they are deposited at the basement. So when complement is activation, it leads to some factors. Remember, you talked about C5A, C3A. You remember those? The C5A and the C3A.
Yes.
And the importance, do you remember the importance of those protein or factors, complement factors?
Yes.
What is it, the lady? C3A and C5A are chemoattractants. So they lead to, or they attract the neutrophil, other cells, neutrophils, which play a role in that inflammatory reaction. So activation of complement brings about recruitment of polymorphonuclear cells, which result into degradation and secretion of enzymes that result into tissue or vascular damage, which may result now in this case, vasculitis. The same applies when the deposition is in the tissue, not in the vascular lining. So when in the tissue, it results into tissue damage or tissue injury. So in others, it is localized. Like what happens in an insect bite, farmer's lung, pneumonitis. So the reaction is localized in one area. In serum sickness, there is saturating immune complexes, and they can be deposited in capillary beds, leading to vasculitis. Damage mechanisms, same applies as that one in others. There is complement activation, recruitment of neutrophils, leading to tissue damage. What we see in glomerulonephritis and rheumatoid arthritis. Type 4, what we know as delayed hypersensitivity. Cell-mediated, now the previous 3 types, all of them were antibody-mediated. What differentiates this type from the previous one? This one now is cell-mediated, and it is delayed. It takes some hours to even days. It can be up to 78 hours before eliciting the symptoms. So it involves T cells. First contact sensitizes a person, and then subsequent contacts elicit a reaction, which is a delayed reaction. Delay is due to migration of macrophages and T cells to the site of foreign antigen. Reactions are frequently displayed on the skin, itching, redness, swelling, and pain. We have a classical explanation of type 4. The classical explanation is in tuberculin skin test. What I mean under tuberculin skin test, it is a screening test for whether a person has ever been exposed to Mycobacterium tuberculosis without necessary formation of the disease. I think in the same previous semester, you talked about Mycobacterium, and you talked about an infection and a disease. So, and I think Professor Joel must have told you that most of us are actually already infected without even knowing, infected from TB without necessarily developing into disease. So how we can determine that an individual X has ever been exposed to Mycobacterium tuberculosis is through a screening test known as tuberculin skin test, or commonly known as MAN2. I think, indicate it here. So MAN2 test or tuberculin skin test illustrates well the occurrences of events that happen during type 4 hypersensitivity. So basically what happens when someone is already exposed, for instance, if you've ever been infected with TB, and most of us are without even your knowledge, when this purified protein derivative, or what we know call tuberculin, the latex, the protein that is introduced in the skin in intradermally, brings about a reaction, and that reaction actually takes some time. It is a delayed reaction, takes a few days, maybe 2 to 3. So the sensitized individual who has ever been exposed to TB organisms, the T cells, remember now here we are dealing with T cells, that T cells are in memory, T cells now get differentiated into cytotoxic and helper T cells. In this case of tuberculin, it is helper T cell that result into release of cytokines. Those cytokines bring about immigration and recruitment of neutrophils and macrophages. Those neutrophils bring about destruction of the tissue, which result into swelling and erythema or reddening. The classical presentation in a MAN2 test. Am I making myself clear to someone?
Yes, sir.
Okay. So that's what happens in hypersensitivity type 4. The same applies to those that are hypersensitive to latex in gloves and condoms. Contact sensitivity in those plants poison oak can poison ivy. Then the metal, nickel, chromium, dye, and drugs, penicillins. A contact sensitizing agent is usually a small molecule that penetrates the skin, then binds to self proteins, which make the protein now look foreign and can elicit the antibody. So basically, that's what happens in sensitization in delayed or type 4 hypersensitivity. It also helps in fighting the intracellular. And if you remember, TB is an intracellular microorganism. It only affects our cells, especially macrophages. So under effector phase, activated T cells secrete cytokines. We also have macrophages that secrete interleukin 1, interleukin 6, and interferon. Chronic inflammation, granulation, leading to lump of T cells and macrophages that are seen in those hives or urticaria, the hives, the swelling. In delayed type hypersensitivity, antigens are intracellular pathogens or contact antigens like in leprosy and poison oak or AV. So this is what happens in tuberculin test or MAN2 test, tuberculin skin test. So the purified protein derivative or tuberculin is introduced intradermally in the forearm at this site, left for 48, 73, 72 hours. So for the reaction to take place. So the reaction is like how I've explained later on, earlier on. If someone has ever been exposed to TB, what happens, the T cells, that memory T cells are differentiated into the new helper T cells. These helper T cells bring about, they secrete cytokines, which leads to migration of macrophages. Macrophages also lead about to secretion of other cytokines that import or lead to recruitment of neutrophils, which result into tissue damage. So the tissue damage is seen. First of all, we have a lump of those cells on this site. Then we have damage, reddening as a result of damaged tissue. So there is measurement of the induration. So there must be, you have to touch that point and endeavor that there is induration or some swelling. So what we measure actually is an induration, not necessarily the entire reddening part, which is not. So we have to measure the induration where you feel there is a swelling. You mark and measure with a ruler or a caliper and see that at least the minimum cutoff point is 5 millimeter, but for a normal human being who is immunocompetent, at least it has this induration or swelling has to be 15 millimeters. So that's an explanation of type 4 delayed hypersensitivity reaction. That's it for hypersensitivity reactions. Any questions before we briefly introduce?
Yes, Doctor.
Excuse me, sir.
Yes, ma'am.
Good afternoon.
Good evening.
Oh, okay. I'm taking you back to type 1 hypersensitivity.
Okay,
you said it doesn't activate the complement system. So what would cause hyperactivity or hypersensitivity in case you're exposed to the allergen for the second time? Yeah, that was my question. Thank you.
Who can help me answer that? Because we took so much time.
Histamine and other inflammatory mediators.
What brings about histamines and other inflammatory mediators?
IgE.
The bursting of bust cells.
What brings about bursting of bust cells? Our question is clear. There is no complement. What brings about effects of type 1? On the second exposure, she was very specific.
Excuse me, sir.
Yes, sir. Sorry? Go ahead. Hello?
Hello, sir.
Okay, let me answer. So what happens in that case? Yes, can you hear me?
I remember you said it before that on the second exposure, Hello?
Hello, we can hear you. Hello? Can someone hear me?
Sir, I think you said that.
Okay, no, let me handle it such that we do not take too much time. So basically what happens is that in sensitized individuals or individuals who have already been sensitized or exposed to allergen or antigen, on subsequent exposure, remember those people, the first exposure induced formation of IgE that got bound to surfaces of mast cells and basophils. So on subsequent exposure, there is cross-linking of those bound antibodies, IgE, by the antigen. The cross-linking brings about activation of mast cells and basophils, leading to degranulation and thus subsequent release of pharmacologically active mediators, for example, histamine and the sisters. So there are these histamines that are associated with the clinical picture that we see in hypersensitivity type 1 individuals. I hope that is clear.
Yes, sir, it's very clear now. Thank you.
Hey, doctor.
One last question. Yes, please.
Can't maybe hypersensitivity type 2 lead to type 3?
No, sir.
Or type 3 to type 4?
No, sir, because we have different parameters and elements which are totally different from one another.
Thank you, doctor.
Yes, sir.
So for me, I didn't get, sir.
Yeah, yes.
For me, I didn't get clear the difference between type 2 and 3.
Oh, yes. So under type 2, which is cytotoxic hypersensitivity, here we are dealing in most cases, we are dealing with internal antigens. Antigens on the red blood cell surfaces. So there is cytotoxicity. Cytotoxicity means there is breakdown or destroying of cells. So how are these cells destroyed? In instance of a blood transfusion, where there is poor matching, cross matching of blood, the antigen antibody. Now the antigen is on the surface of red blood cell. Gets attached to an antibody. This attachment, antigen antibody, on the surface of a cell leads to activation of complement. The activation of complement results into the final cascade formation of MAC, membrane attack complex. It's this MAC that destroys or lyses red blood cell and will result into, in this case, into hemolysis because we are destroying a blood cell. That is now in type 2. We went ahead and talked about what happens in hemolytic disease of the newborn, where we have O negative mother conceiving to a rhesus positive fetus. At birth, the mother gets sensitized because there is mixing of blood during childbirth, and now develops antibodies against rhesus positive antigens. On the second pregnancy, if that mother is not prevented, on the second pregnancy, the antibodies cross the placenta and attack the antigens, specifically the rhesus antigens in the subsequent fetus or second fetus, leading to hemolytic disease of the fetus. That is in type 2. Type 3 basically is an immunocomplex. So we have an antigen, we have an antibody, they form a complex, they are either deposited in capillary beds or in tissue, they result into activation of complement and recruitment of inflammatory cells, which result into the mediators and enzymes that destroy the tissue. I hope the difference is now clear.
Related, they end up forming complements.
Yeah, okay, in both, there is complement formation. In both, there is antibodies, IgM and IgG. But the scenarios in both are totally different. In second, we have lysis of cells. In third, it is a complex, an immunocomplex, which is deposited either in tissue or in blood capillaries that result into recruitment of other cells, leading to inflammation. Remember, in 3, we have an inflammatory reaction. In 2, we do not have an inflammatory reaction. In 2, we have lysis, destruction of cells.
So the main difference there is recruiting of inflammatory agents.
The difference is, anyway, you understand when you read. Go to go online, look for Review of Medical Microbiology and Immunology. It is a precise textbook. Warren Levinson. It will teach you well, and you'll have first principles. Otherwise, we may take the whole day here.
Okay, thanks.
Okay. So let's briefly introduce another topic. So as I've already said, so today we are also going to talk about, but it's your assignment actually. I'll only give you the PowerPoint, the slides later. Are we still there? The class is shrinking, sorry. Hello?
Yes,
Yeah,
yes, Bob. We are on.
Okay. So basically, our other topic of discussion this evening is immunodeficiency disorders. So note that we shall not go through the entire PowerPoint presentation. We shall have it as our take-home assignment. Oh, we are already home. As our assignment home, and read textbooks and get conversant with the different disorders that appear in this category. So basically, immunodeficiency disorders are categorized into two broadly. They are categorized into congenital or primary disorders, or categorized as acquired or secondary disorders. So we have congenital, we have acquired. So in congenital, they are also subcategorized into humoral or B cell, or cellular or T cell deficiencies. But we also have now that's specific. Both B cell and T cell deficiencies are specific, but we also have non-specific, which are deficiencies of complement or deficiencies of macrophages or phagocytes.
Inflammatory agents.
So deficiency, any deficiency related to any of those kinds lead to an immunodeficiency disorder. So basically, defense mechanism of the body is impaired. When it is impaired, then we are prone to recurrent microbial and viral and protozoal infections, depending on which arm, depending on which category we are dealing with. We also get susceptible to malignancies. Specific, we have humoral or cell mediated, B cell or T cell mediated. Then non-specific, phagocytes and complement. So deficiencies of phagocytes or complement lead to non-specific immunodeficiency disorder. So immunodeficiency is a state in which the ability of the immune system is compromised or entirely absent to fight against infectious diseases or cancer. So as we've said, there are two types, primary or congenital or inherited, but we may have congenital, which may not be hereditary. Secondary or acquired. Immunodeficiency can be specific or non-specific, as we've said. So now congenital. So in congenital, we have humoral or B cell deficiencies, cellular or T cell immunodeficiencies, combined both B and C. So you find a disorder where there is a deficiency of both B and T cells. So we call that one combined immunodeficiencies. Then we may have disorders of complement and disorders of phagocytosis or phagocytes. So now if we are to talk about humoral disorders or immunodeficiencies or B cell defects, those are some of the examples, but there are so many defects or immunodeficiency disorders. So those are some: X-linked agamaglobulinemia or Bruton's disease, selective immunoglobulin deficiency, transient hypogammaglobulinemia of infancy, common variable immunodeficiency, immunodeficiencies with hyper IgM or commonly known as hyper IgM, then transcobalamin 2 deficiency. So these are under humoral or B cell defects. So this is X-linked. So basically Bruton's, more common in boys. So disease not apparent until 6 months of age. Recurrent bacterial infection with pneumonia, pneumococci, streptococci, and so forth. Though in this case, remember what we talked about in the previous lecture. I've told you that B cells are responsible for bacterial or immunoglobulins, but T cells are responsible. I think you must have talked about it in previous lectures, that T cells are responsible for viral infections. So in this X-linked or Bruton's disease, patients respond normally to viral infections. So there is no effect, but they tend to incur recurrent bacterial infections. All classes, very key, all classes of immunoglobulins are grossly depleted. So depletion of cells in BASA, dependent areas of lymph nodes, and as I've said, X-linked disorder usually affect boys more than girls. Okay, So cell-mediated immunity is not affected. So thus, the viral immunity is competent. So selective immunoglobulin. So we shall see. You'll have to read all these. So now this one is cellular. So cellular, we have thymic aplasia, or known as thymic hypoplasia, chronic mucocutaneous candidiasis, how the defects in T cells bring about chronic mucocutaneous candidiasis. But the beauty is that in this condition, it does not affect our lifespan. Someone can live with it. But of course, there are some interventions. Purine nucleoside, you will read. So that is under thymic, usually chromosomal abnormality, and intrauterine infection, neonatal tetany, and we shall you read and understand what brings tetany. Also known as Diogenes syndrome. Okay, so I think so these are phagocyte deficiencies, chronic granulomatous disease, myeloperoxidase deficiency, Chediak Higashi syndrome, leukocyte 6G6PD deficiency, and Jobs syndrome. Disorders of the complement system. Then now those who are primary, now acquired immunodeficiencies or secondary immunodeficiencies, malnutrition, malignancy, infections, metabolic disorders, cytotoxic drugs, humoral and T cell mediated immunodeficiency, which are acquired. In cell mediated, we have Hodgkin's lymphoma, Hodgkin's disease, obstruction in lymph circulation, repromatous leprosy. We have tuberculous leprosy. I hope you differentiate the two. Then measles. How to identify type of immunodeficiency disorder. Younger than 6 months, usually abnormality in T cells. 6 to 12 in both B and T cells. Older than 12 months, usually it is a B cell disorder. And that's it, ladies and gentlemen.
Thank you, Doctor.
Wanji?
Have a great evening, and endeavor to read about immunodeficiency disorders.
But sir, how can we get these notes?
Sir, I am going to send them to your class representatives.
Starting with, was it immunology? All immunology notes.
Oh,
you mean you go on
you mean lecturers have not been sharing their slides?
On MLS,
Sorry?
when you get them from LMS, they are zipped, they can't be opened. Yeah.
Okay, but we usually send them to your, maybe unless you do not have email addresses. But we share them with your class representatives, and then we upload on LMS. But more effectively on your any questions? Hello? Hello?
We're getting you.
Okay. You do not want to bid farewell to me.
Thank you, sir, for the lecture.
See you next time, physically, soon.
All right.
Blessings.
So have a nice weekend, but you have cheated us on the last group of slides. You have really jumped not even 15 minutes and you're done with 43 groups of slides.
But I told you that it is an assignment. Stop being weak, young lady.
No, it's not being weak. At least you take us through.
No, but it's an assignment. What do you understand by an assignment? Am I your group mate? Actually, I did a favor, and it is not even allowed. An assignment is supposed to be an assignment or take home. You go read. Because when I give you, you just copy my notes. You'll not read and understand these disorders.